Welcome back to Antibiotic Answers. My name is Isaiah Ratz, and today we'll be talking about syphilis. Syphilis is caused by Treponema pallidum, which is a thin, spiral-shaped bacteria. It spreads mainly through sexual contact, but it can also be passed from mother to child during pregnancy. The infection moves through stages: primary, secondary, latent, and tertiary. Despite being treatable, syphilis is still a major global health concern, and cases are rising in the United States. Primary syphilis usually starts with a single painless sore at the site of infection. Secondary syphilis brings a rash on the palms and soles, mucus patches, and wart-like sores. The latent stage has no visible symptoms, but the blood tests still remain positive. And if untreated, syphilis can progress to tertiary disease, which may affect the brain, heart, or skin. And remember, neurosyphilis and ocular syphilis can occur at any stage of the disease, not just that tertiary stage. The gold standard for treatment is benzathine penicillin G, 2.4 million units intramuscularly. For early syphilis, that's a single dose. But for late or unknown duration, it's given weekly for 3 doses. For neurosyphilis and ocular syphilis, we switch to intravenous penicillin G for better central nervous system penetration. Congenital syphilis can only be treated with penicillin G, as there are no safe or effective alternatives available. It's important to know that oral penicillin, such as penicillin VK, does not work for syphilis. If a patient has a penicillin allergy, doxycycline or ceftriaxone may be considered, but during pregnancy, desensitization is required so penicillin can still be used. And finally, there are ongoing shortages of Pen-G in the United States. Because of this, the CDC recommends prioritizing supplies for pregnant patients and congenital cases. To diagnose syphilis, we use 2 different blood tests. One test looks for disease activity and helps us track response to treatment, and the other confirms infection and usually stays positive for life. Using both together is essential because relying on just one can give false negatives or false positives. After treatment, follow-up blood work should be done at 6, 12, and 24 months to confirm response. And since HIV and syphilis often overlap, HIV testing is recommended for all patients with syphilis as well. Congenital syphilis is on the rise in the United States, often linked to missed prenatal screenings. The CDC recommends syphilis testing at the first prenatal visit, again in the 3rd trimester if the patient is at high risk, and sometimes at delivery. Untreated maternal infection can lead to stillbirth, neonatal death, or lifelong complications for the infant. Penicillin G remains the only recommended treatment for both mother and baby. When it comes to stewardship, first step is proper staging. Treatment depends on where the patient is in the disease course. Secondly, we also need to avoid unnecessary repeat doses. So for early syphilis, 1 dose is usually enough. Third, we need to counsel patients about the Jarisch-Hersheimer reaction, which is a short-term fever and body aches that can happen within 24 hours of starting therapy. And finally, partner treatment and public health reporting are critical to prevent reinfection and reduce community spread, especially when medication shortages are such a concern. To summarize, penicillin G is still the cornerstone of syphilis treatment, especially in pregnancy. Oral penicillin does not work. Correct staging ensures patients receive the right duration of therapy, and ongoing shortages mean we must prioritize pregnant and congenital cases. And with congenital syphilis rates climbing, routine prenatal screening and partner management are more important than ever. Thank you for listening to this episode of Antibiotic Answers. If you have questions, please reach out to the CAP Center Antimicrobial Stewardship Pharmacist, Dr. Emily Perry.